Blood Bank Guy Essentials 007.
So the more acutely injured, the more ill patients, the more grievously injured individuals, they died before their transfusion support could approach this sort of touted 1-to-1 type of high ratio criteria.
Hi, everyone. Welcome back to the Blood Bank Guy Essentials podcast. This is Joe Chaffin. I am your host. I am super excited to share with you today my conversation from May 2016 with Dr. Minh-Ha Tran from the University of California Irvine. Min is going to talk to us and give us a lot of really useful information on massive transfusion. There's a whole lot for him to tell, so I'm not going to take up any more time at the beginning. I will be back with you at the end, but let me just say this one thing. The opinions that Dr. Tran and I express on this episode are just his and mine. They don't necessarily reflect those of the organizations with which either of us is affiliated, and neither he nor I have any relevant financial disclosures. And with that out of the way, I'll be quiet and let you listen to my conversation with Dr. Minh-Ha Tran. All right, everybody, welcome to episode 007 of the Blood Bank Guy Essentials podcast. I am honored today to have as my guest Dr. Minh-Ha Tran from UC Irvine. Min, welcome to the podcast.
Hi, thank you. It's nice being here.
It's great to have you. I want to let everyone know a little bit about you. You are an associate clinical professor at the UC Irvine School of Medicine, but you're a little bit different than most of the folks that I talk about. Not that that's an insult or anything. You're awesome, but you're in a couple of different departments at UCI. You're in the Department of Pathology and Lab Medicine, and you're also in the Department of Internal Medicine. I want to hear a little bit more about that in just a second. You're the Associate Medical Director for the Division of Transfusion Medicine and Apheresis. Min provides medical oversight of the UCI blood donor services and also does consultation services for patients requiring therapeutic apheresis at UCI. He has an interesting background for those of us in blood banking. It's a little bit different than the so-called traditional pathway. He did internal medicine training at Mercy Hospital of Pittsburgh and then followed that with fellowship training in transfusion medicine at the National Institutes of Health. And Min, how long have you been at UCI?
Since about July of 2009.
Awesome.
Almost 7 years now.
Awesome. And you and I have worked together on a couple of occasions, taking care of patients at your institution, just for full disclosure for everyone, which has been fun. And that's how I actually got to know you. I would like to, if you don't mind, I mentioned that your background is a little bit non-traditional, I guess, quote unquote, for those of us that have, that came up as pathologists and moved into blood banking. So why don't you tell us a little bit, if you don't mind, what is that got you interested in blood banking, and how did you set down along this pathway?
The path was an interesting one. I'm probably one of my most memorable cases when I first started internship was an elderly gentleman with CLL, and he had Evans syndrome. Oh. And the hematologist-oncologist at the time was very instrumental. He's like a mentor to me, and he would tell me to have the slide ready, and he would show up at the microscope and take me through the slide and say, these are microspherocytes, et cetera, et cetera. And I think that started getting me really interested in immunohematology. Mm. And then throughout my residency, there have been some interesting cases of coag and other things. And as a senior resident, I was able to do a rotation with Dr. Bontempo over at University of Pittsburgh Institute for Transfusion Medicine, who runs a coag rotation. And I didn't even know about blood bank at that time. And I showed up to the first day of the coag rotation, and Joe Kiss says to me, he goes, well, the coag rotation is in the afternoons. If you're interested, we get you over to the university and do some blood banking in the morning. Uh-huh. And I was like, oh yeah, sure. So that's kind of what started it.
What's blood banking again?
Yeah.
Yeah. Awesome.
And then when I got to fellowship, I just found that blood banking had, it encompassed everything about hematology that I was really interested in. without all the really sad oncology stuff. So,
yes.
so this is very cool.
Yeah. Yes, absolutely. Well, and I want to thank you because you still keep your hand in hematology. I know a little bit, and you actually just finished this past weekend before we're recording this in the beginning of May of 2016. Doing a massive hematology symposium at UCI. I understand that went really well.
Yeah, we were really excited. We had a great turnout for our first annual. It was at the Disney Grand Californian Hotel, and we had about 65 people there, and we had exhibitors and everything, and it was just really, really positive feedback. I just got through reading the course evaluations, and I think it was a nice boost to my ego.
Good deal. Well, I know you well enough to know that it was, I'm sure that it was awesome. I actually wish I could have been there. Well, today, Min and I are going to discuss something it's a topic that is, I guess you could call it a hot topic. It's something we've certainly been talking about for quite a while now. And it's something that I think that it's really important for blood bankers and clinicians to get a really solid handle on as best we can anyway right now. There's a lot of data that's developing in this field. And we're going to talk about massive transfusion. Massive transfusion, no pun intended, and it's a terrible pun, is a massive issue for us. Blood banks and blood bankers probably don't have a much more stressful situation that comes up aside from massive transfusion. It's a big deal. Things happen. People go crazy in terms of just the amount of product that's needed, the short time frame that is needed in, and what Min is going to do for us is just take us through a little bit how we should be thinking about these things, both from our side as well as what you should work on process-wise with your clinical staff. So what we're titling this talk or this discussion is the who, where, what, why, when, and how. I think I got that in the right order, of massive transfusion. So who, what, sorry, I'd say I screwed it up. Who, where, what, why, when, and how of massive transfusion. So, Min, why don't you start us off with the who? When you say the who of massive transfusion, who are you talking about? What kind of patient group are we discussing here?
Sure. So this is the portion where we define our population. So massive transfusion, historically has referred to trauma patients, and patients fitting into a massive transfusion criteria are typically defined as those who've received 10 or more units of red cells over 24 hours. Alternatively, they can be defined as patients who receive more than 4 units over 1 hour with an anticipated need for continued blood component support, or replacement of greater than 50% of their total blood volume by blood products within 3 hours. So these definitions, in some regard, are retrospective, right? So you don't know when you've achieved or met the criteria until after it's occurred.
Right.
Yeah. So
that's a little bit of a problem, right?
It is, because you kind of want to initiate rapidly. So I was kind of searching around the literature, and I found a paper by Nunez et al. In Journal of Trauma, and they developed this scoring tool called the Assessment of Blood Consumption score. And so they have this large retrospective cohort of level 1 adult trauma patients, and they were able to look at the following scoring parameters. So penetrating mechanism, yes or no, systolic blood pressure 90 millimeters mercury or less, heart rate 120 or greater, and focus assessment with sonography for trauma scan or FAST scan being positive is 1 point. So scores of 2 or higher were found to accurately predict those who went on to have a subsequent need for a massive transfusion. The sensitivity and specificity were around 75 and 86%. So that's a nice, quick way to predict who is going to go on to get massive transfusion.
So just interrupt you for just 1 second. I'm sorry about that. This is, by the way, for everyone to know, I'll have this reference on the show page for this particular episode, the Nunez paper that Min just mentioned. But just practically speaking, is that something that have you seen that be widely used, or is that something that's obviously it's mentioned in a paper and it looks great? I personally haven't seen anyone or seen anyone talking about using this. Have you seen it used?
I can't say that I'm, in the trauma bay at the time that these things are occurring.
Right.
I think I put it in there in response to that idea that, if you're waiting until 10 units are transfused in 24 hours, gosh, the cat's out of the bag, right?
Right.
You should have activated by then. I think the trauma surgeons are just very experienced.
Yep.
They probably do this in their head, sort of spontaneously and instantaneously, that they are able to evaluate a patient, and they have extensive experience, and this happens probably automatically for them.
Yeah.
And that they just go ahead and activate the massive transfusion protocol,
right?
Sort of, instinctively.
So is it fair to say that while they have tools like this, and I'm sure that they use it, that for us in the blood bank, maybe massive transfusion is defined as when the trauma surgeons say it's massive transfusion? Is that making it too simple?
No, that's exactly what. Exactly.
Yeah. So functionally speaking, nobody is sitting in the OR probably going, okay, well let's see, that's 6, that's 7. Well, we're not to 10 yet. It's more of a judgment by the clinicians, and more of a, hey, this is a bad situation. This looks like we need to activate the massive transfusion protocol kind of deal. Is that fair?
Exactly. Yeah.
Okay. And we keep saying trauma. Is it all trauma, or are there other situations in the hospital where massive transfusion can occur?
Yeah, actually, we have a similar massive transfusion protocol that we developed with our OB-GYN colleagues to deal with maternal hemorrhage.
Right.
And I think this sort of massive transfusion paradigm, it is also being implemented for other sort of non-trauma situations where you have exsanguinating bleeding, like massive GI bleeding and things like that. It's a very convenient way to provide rapid blood support.
Okay, excellent. So we'll get more to that in just a few minutes in terms of the specifics of that blood support. But is anything else on the who? So we've discussed the who of massive transfusion. Are we missing anything there, Min?
I think that's pretty good.
Okay. Outstanding. Good job, us. Yay.
Yay.
So that's the who of massive transfusion. Let's move on and talk about the where. And I think you already started down this pathway a little bit. Where in the hospital do we typically see these?
Oh, yeah. So the where is a complicated issue. And, we in the blood bank, we're in a fixed site, and we're needing to issue blood rapidly. And, there are many, many players in the massive transfusion scenario. So you have a patient that is, brought in from the scene of an accident or something, and they may be shuttled through the ED into the trauma bay. They're assessed by a team of trauma professionals. They may be at some point shuttled to the CT scanner. They may go up to the OR. They may go from the OR to interventional radiology if they need something embolized, back to OR, maybe go up to the SICU. So all of these transitions in various sites of care that can happen rapidly, right, are associated frequently with different staff members and people who may not be aware of all the protocols. In addition, specimens are being sent to and from the lab from potentially these different locations, and blood is being requested, right, potentially to and from these different locations. So the where is an important issue because, most of the time the blood bank is not, we're not located in the same location as the resuscitation is occurring. And what I always say in hospital is, these 30 tons of concrete and steel that separate us from the OR or us from the trauma bay I found that it interferes with the natural clairvoyance that blood bankers have. So we don't know what people are thinking. So right, this where engenders a critical issue of communication. And that's like, tell us what you need and where you need it. Right. And we'll send it to you. And if there's a runner involved, that runner needs to be trained. And in fact, some centers actually arm the runner with a cell phone, and then the runner is sort of like always accompanying that patient or whatever. So the where is really important because we don't always know where to send the blood. And if we send the blood to if it's requested in the trauma bay, but by the time it gets there, the patient's already in the CT scanner and so on and so forth, you can see it can become really problematic for that patient who needs the blood products.
So, you said a couple of things that are super important there. I've seen you in a lecture that you gave about this. I've seen you kind of diagram that out for blood bankers to try and understand the complexity of that care environment. And your diagram is actually hilarious. Can you describe it for me a little bit?
Oh, yeah. I have like these spheres all over the page, and they each represent a location of care. And then one sphere is the lab, and the other sphere is the blood bank. Mm-hmm. And they show these dotted lines that represent specimens going back and forth to each little area of care. Right. And then these straight lines that might represent blood components going back and forth from the blood bank to the various sites where the patient might be at that point in time. So it's meant to look overly complicated. That's the whole idea. That's kind of how real life is.
It's not as
organized as we might want. Yeah,
exactly. And we have. I think that in blood banks we sometimes are a little bit unrealistic about the way our blood products should be handled. We're blood bankers, so we take a very personal interest in our blood products and making sure that they're used appropriately and used in the right places. But we have this very linear thought sometimes that, by God, I'm issuing it from here, it's going directly to there, one unit at a time, and that kind of paradigm, it really blows up in massive transfusion, doesn't it?
Yeah, it does.
For sure. Well, you said, and the other thing that you said that I want to talk a little bit more about before we leave the where is the communication. And I know we'll get to this a little bit more when we talk about the products that we're issuing, but the importance of having that communication not only at the time this is happening, but a pre-discussion, basically talking about this stuff way before it happens. And I don't want to jump ahead. Forgive me if I am in your who, where, what. But can you talk a little bit about that and how practically speaking can blood bankers have those kind of conversations so that when this incredibly complex environment is occurring, that we know what it is that we're supposed to do?
Yeah, so I think sitting down with all of the key stakeholders, so the trauma service, the ED physicians, the anesthesiologists, runners, perioperative nursing staff, etc., having them all in the same room and developing a massive transfusion protocol together is, so that everybody's on the same page, and recognizing that there are different members of the team. Some, for example, in our center, the trauma surgeons have an expectation for high ratio transfusion when that patient hits the OR, but they're so busy operating that really the true sort of transfusion ordering process and transfusion support becomes the realm of the anesthesiologist. Right. So if the anesthesiologist is not aware of the expectation of the trauma surgeon, and the trauma surgeon's busy operating, then that right there could be sort of the what I like to call the blue drape separating the two teams as also a big barrier to communication, that the anesthesiologist may not be aware that massive transfusion was activated on this patient, right? Because the patient came from the trauma bay to the OR and that communication piece didn't occur. So then the anesthesiologist is like, okay, well, here's what the TEE shows. This is what my blood pressure and heart rate show, I think, and here's my hemoQ, and then they start doing their own thing, So the communication is really important, not just between the site of care and the blood bank, but also between providers, so that everybody's on the same page and they know what they want, what the expectation is.
And you're 100% right. I always tell people in labs where I work that the work of massive transfusion is largely done. And this might be oversimplifying, but the work is largely done. The groundwork it has to be done way before it happens, because if you're trying to figure out the process while it's occurring, you're dead.
Yeah.
way too late for that. I don't need to over dramatize it, but okay. So we've talked about the who, the kind of patients that get massive transfusion, and we just covered the where. and the importance of the complexity of the process, as well as the importance of making sure that communication occurs. So let's move on and talk about the what. So we've done the who, the where. Here's the what, and the what. When we talk about massive transfusion, what are we talking about? What's considered kind of the standard of how we transfuse these patients that are undergoing massive transfusion?
Sure. So fixed ratio transfusion or massive transfusion is an attempt to recapitulate whole blood, right? So you're using fixed ratios of usually red cells to plasma to platelets to try to in some way reformulate effectively whole blood. So traditionally, the fixed ratio, or when people say 1-to-1 or something like that, they're referring to the number of units of plasma to the number of units of red cells. And this definition has now broadened to include platelets, and some centers are including cryo with every second or third round or something like that. So the addition of platelets to the definition can lead to confusion, right? So what I like to tell people is, depending on where you train or where you practice, that center might predominantly use whole blood derived platelets, whereas other centers may predominantly use apheresis platelets. So it was a big culture shock for me coming back to California and finding that California is an apheresis platelet state. So I always know when it's July, when I get an order of 6 units of platelets for a patient, I'm like, whoa, that's like my whole blood bank inventory, dude, because they probably trained at understandably at a center that was accustomed to using 6-packs, right? So obviously that will affect your ratio. So if you're trying to adhere to, when you hear 1-to-1-to-1, that's typically referring to the whole blood derived platelets, where you get 1 whole blood derived platelet per 1 red cell. So that's like what you would get with whole blood, right? But a center like ours, it's like apheresis platelets. You hear things like 6-4-1 or 6-6-1, where you're 1 apheresis platelet to 6 units of red cells. So that ratio is referring to the number of red cells, plasma, and platelets that you get. And these precise ratios, they vary between centers. So every center has its own massive transfusion protocol, and these different ratios may vary between these various centers. So the basic idea is that the clinical team identifies the who. Hopefully they know where they are, which is sometimes difficult. And then they say, okay, this patient needs massive transfusion. They activate the massive transfusion protocol. Presumably they have, a very robust access in place. Something like an introducer in a subclavian vein, and they have these things called Belmont rapid infusers, where you can just dump lots of products into the patient very rapidly. But you can, before you patient, that's a big deal, right? You want to transfuse, but you really need a very robust access first before you start resuscitating these patients. But then the team would say, okay, this patient merits massive transfusion. They call the blood bank, say, we're activating massive transfusion protocol. Send us the first round of product. We send the whole, 6-6-1 pack down to wherever they are. They transfuse the whole pack, everything. And then they reevaluate and they say, you know what, we need another one. So they call us back, request another one, we send it. And in the meantime, you send it, and then the blood bank, because now you're on massive transfusion protocol, is now thawing the next round of plasma, allocating the next apheresis platelet pack. They're preparing the next red cell units and labeling and doing all that stuff, so it's ready to go as soon as we get the word from the team. So.
And that's, Min, let me stop you there for just a second, because that's really important, practically speaking, and beginners and people that are early in their blood banking career can kind of miss that. So as you mentioned, I guess I would say you mentioned the California Center thing, and I certainly more than California. And you happen to do some of your training in Pittsburgh, obviously, which is well known to be a big user of whole blood derived platelets. I had a conversation with Mark Yeaser a few episodes ago about that. But in most places around the United States, certainly not all by any stretch, but I would say the majority, they're using those apheresis platelets. So functionally speaking, a massive transfusion pack in most places, again, is this fair to say that it's usually in the range of 6 units of red cells, in the range of 4 to 6 units of plasma, and 1 unit of apheresis platelets? So functionally speaking, that's primarily what we're talking about, right?
Yes.
Okay. And just being really practical, how does that look? I mean, or is it all going out in a big box? Is it I'm sure I know places differ, but how are those put together? When you say a pack, what are they physically picking up from the blood bank?
You'll have an igloo or
Mm-hmm.
something like to that nature for the red cells. And then some folks will have a different sort of a carrier for the plasma. And then the unit of platelets will be, so you might have like the runner will come
Mm-hmm.
and, have an igloo in one hand, and then in the other hand, they'll have like a plastic bag, and,
Right.
all that stuff is sort of mixed in. The idea is they get to the site of care and it just all goes into the patient simultaneously. So we usually tell them to hang the platelets separately, because oftentimes this is going through a blood warmer. So we don't want the platelets to go through the blood warmer, but that's usually how it looks.
Gotcha.
They just come and pick up a bunch of stuff. Mm-hmm. It's like a shopping trip.
Shopping trip where the groceries have been picked out for you already, right?
Yeah, exactly.
Here's pack 1, here's pack 2. And that's a key, because sometimes places can get in trouble when I don't want to say the anesthesiologists are picking and choosing what they're transfusing, but you said something really important. The intent is you get the pack, you transfuse the pack, you ask for the next pack, rather than saying, okay, I've given all of the red cells, but I haven't given the other ones yet. Can you send me more red cells? Is that sometimes a struggle?
Yeah, I think that's where sort of the expectations issue is, or the communication. If the patient presents to the OR and whoever is managing the transfusion support is unaware, or doesn't know that right now we're expected to be following NTP for this patient, then they may just automatically revert to a la carte ordering. So I call it a la carte. So they say, give me 2 units of red cells and a unit of FFP, and I think we're okay on platelets for now, but let's so that might be sort of their automatic sort of transfusion style. And if they didn't receive the memo that this patient's under massive transfusion, then they may not know. And the communication is key. Yeah,
that might be a recurring theme, man. We might hear that again.
Yeah, exactly.
Okay, so with that being said, so we've the massive transfusion pack, as it were, that will vary from place to place, as you said. Okay, let's do the why. Why do we do that, man? Was there kind of a beginning point of this? I think that most of us have heard this fixed ratio transfusion, as you mentioned, and the massive transfusion packs have been in use, widespread use for the last, 8-10 years or so. So why did we get there? How did this start?
So it looks like this originated from a paper by Borgman and colleagues. So what Matthew Borgman and his group did was they performed a retrospective study of 246 patients at Army combat support hospitals. So this is sort of the much touted quote unquote Iraqi combat data. So this was a retrospective analysis of data for trauma patients admitted to combat support hospitals in Iraq between November 2003 and September 2005. And the data was derived from the Joint Theater Trauma Registry maintained by the U.S. Army Institute of Surgical Research. So patients were included if they met this criteria of 10 units of red cells over 24 hours. And each of those patients' respective medical data were collected. And so about 4.6% of patients, or 246 out of 5,293 patients admitted, met this criteria. So these 246 patients were then divided into groups based upon the ratio of plasma to RBC units transfused. So just to, as an aside, they were separated out by the transfusion ratios, as opposed to trying to find groups of very similar patients or identical patients, and then applying an intervention, which is the typical randomized control trial.
Right.
In this case, what they did was they took this sort of ratio and then let the chips fall where they may regarding the characteristics of those different patient groups. And then they made, so that's one point to make. So what they found was, in terms of mortality, So they defined a low ratio transfusion as if you divide the plasma to red cells and you get 1:8, so that was the low ratio.
Mm-hmm.
So that was an N of 31. Then a medium ratio is 1 to 2.5, and that was an N of 53. And then the high ratio is 1 to 1.4, is an N of 162. And the mortality for these groups was 65%, 34%, and 19% respectively.
And so, I mean, again, they were just to clarify on those ratios. The low ratio ones were people that got a whole lot more red cells than plasma. The high ratio
Correct.
ones that got roughly close to the same number of units of plasma and red cells, right?
Right.
Okay. Go ahead. I'm sorry.
So what came out of this is that if you look at the sort of like outcomes and criteria, baseline characteristics of these patients, you find that the patients in the low ratio group, they tended to die much sooner than patients in the other two groups. So in terms of hours, the mean and interquartile range for time to death was in the low group was only 2 hours with an IQR of 1 to 4. The medium ratio group was 4 hours with an IQ of 2 to 16, but the high ratio group was 38 hours with an IQR of 4 to 155. And those in the low ratio group more predominantly died due to a hemorrhagic death. So it was like 92.5%, 78, and 37% respectively. In addition, compared to the medium or high ratio group, patients in the low ratio group were far more severely injured. So they had a much higher acute injury score for head, neck, and thorax. They had a lower presenting hemoglobin and systolic blood pressure. They had higher presenting heart rates and base deficits, and they were more coagulopathic at presentation. So they had a higher INR. So they were this group was a distinctly different group than what you saw in the high ratio group. But from these data, the authors concluded that among combat casualty trauma cases, high ratio transfusion like 1 to 1.4 was independently associated with an improved survival to hospital discharge. And they actually recommended that massive transfusion protocols should utilize this high ratio transfusion for trauma patients. But given that the time to death occurred within 2 hours for the low ratio group, and the time to death was 37 hours or more for the high ratio group, what this brings up is an issue of survival bias. So the more acutely injured, the more ill patients, the more grievously injured individuals, they died before their transfusion support could approach this sort of touted 1-to-1 type of high ratio criteria. Whereas those patients who were perhaps less severely injured, they survived long enough so that the transfusion support could catch up and achieve this sort of high ratio transfusion. So this is like a survival bias.
That's a key point. Go ahead.
Yeah, and so based on this N of 31 of the low ratio, now this sort of fixed ratio transfusion has sort of become the standard of care. And I'm not arguing with it by any means. I think it has a lot of merits. For example, I think the fixed ratio or massive transfusion type of resuscitation allows interdisciplinary collaboration to develop the protocol. It establishes pathways to more rapidly get the product to the patient who's bleeding. It facilitates communication. We in the blood bank, we know when a patient is very, very ill when we hear massive transfusion being activated. It creates a standardized process to minimize confusion. You request it, you get it, you transfuse it.
Right.
And if you need it, you request it again. I think it has many merits, but yeah, I think it looks like that seems to be the origin of current massive transfusion practices.
That's a great summary. That I think that it's been my experience as well that there are so many benefits to the fixed ratio process, but I think that it is important to understand that it was originally based on something that look, I'm an old Army guy, and I'm always happy when good stuff comes out of military studies, but quite frankly, this study has had a lot of criticism over the years, and I think the survival bias is the biggest thing, as you mentioned. People that the people with the high ratios were the ones that died quickly. And people have argued, well, that just means that they died before you could get them enough plasma, and it's not necessarily the reason that they died. So we don't need to beat that to death. But over the years, blood bankers have kind of, I think, had mixed feelings about this. I think that's certainly fair for me to say. While there are definitely benefits, I think everybody has been a little bit worried on the blood bank side, especially. Well, let's put it this way: trauma surgeons, for the most part, have said, "Yay, good, this works. Standard of care, let's roll." And further, can you get us fresh whole blood? How about that?
Yeah.
But we have been a little more, maybe not necessarily reluctant, but we've wanted a little bit more data. And I know that there have been some recent studies published as we move into the when of massive transfusion. Can you take us through some of the more recent, more prospective type studies that have looked at this issue that have kind of hopefully answered some of these questions, as well as given us an idea of when massive transfusion intervention needs to occur?
Sure. So there was a paper that was recently published in JAMA by Holcomb and colleagues. So this is the Pragmatic Randomized Optimal Platelet and Plasma Ratios, or PROPER study. So this study is a multi-center randomized controlled trial that compared two different ratios. So red cells to plasma to platelets of 1 to 1 to 1 versus 2 to 1 to 1. Mm-hmm. And the study was designed to detect pre-specified differences in all-cause mortality of 10% at 24 hours and 12% at 30 days. And these numbers are based upon the increased sample size that occurred later in the study of 680 subjects. So importantly, this is the primary outcome of the study, the primary outcome that the study was designed to address. Mm-hmm. The study found no difference in mortality at either time point, whether trauma patients were resuscitated with a 1 to 1 to 1 or a 2 to 1 to 1 strategy. So for the 1 to 1 to 1, 24-hour all-cause mortality was 12.7% versus 17% for the 2 to 1 to 1. So the difference was minus 4.2% with a 95% CI of minus 9.6 to 1.1. So that was less than the 10% difference that mm-hmm. the study was designed to detect at that time point. Also, at 30 days, the differences were 22.4% versus 26.1%, with a difference of minus 3.7%, 95% CIs minus 10.2 to 2.7. Again, less than the 12% that the study was designed to detect. Mm-hmm. So this study found no difference in the primary outcome of 24 or 30-day all-cause mortality, whether a 1 to 1 to 1 ratio or a 2 to 1 to 1 ratio was applied. Mm-hmm. So then there was a second study, the Prospective Observational Multicenter Trauma Transfusion Study, or PROMPT. So this is also by Holcomb and colleagues. So this was not an interventional study. This was more of an observational study. And I believe there were 10 centers in it, and each were allowed to use whatever ratios they had already established in their respective massive transfusion protocols. So these were the patients studied were adult trauma patients who were analyzed for in-hospital mortality, and this was based on the plasma to RBC and platelets to RBC ratios at multiple intervals between 31 minutes and 6 hours. They had an interval that they studied at 18 hours. And then a 29-day interval between 24 and 30 days. So in the first 6 hours, ratios of 1 to 2 were or better, or the so-called high ratio transfusion. These ratios were independently associated with decreased 6-hour mortality when hemorrhagic death predominated. But among survivors at 24 hours and beyond, the subsequent mortality risk at 30 days was no longer linked to the ratios that were applied. So if you look at sort of the graphs and data in this study, you can't help but wonder if this is these different time points that they were looking at were sort of a microcosm of survival bias. So if you can get the patient through 24 hours, they're going to survive no matter what the ratios are. Mm. But in that early period, what happens is if they don't survive, if they die within an hour, then those patients who are very egregiously injured, they drop out of the overall analysis. But they're not accounted for because you can't possibly redo the the characteristics.
Sure.
So it's sort of like a microcosm in a way of survival bias is what I would consider it. I guess that's just my opinion. But so then the other study that I like to point out is the Riskin et al. Study. So this is a study at Stanford where they designed and implemented a massive transfusion protocol, and then aspects of that massive transfusion protocol were that they would identify a massive transfusion leader with defined roles for all team members. So this is the communication piece. They would have a defined ratio of 6, 4, and 1 to provide rapid product distribution, and then they would also have 4 units of thawed plasma available at all times. So it incorporates both sort of communication pieces and operational pieces with an overall impact that they would more rapidly get product to the patient. And their outcome was that, so they did a pre-post study of, pre-implementation, post-implementation. And they found that while there was no difference in the ratio of RBC to FFP in the pre to post periods, there was a significant reduction in mortality during the post-implementation phase. So they went from 45% to 19%. And this was attributed to significant improvements in product delivery times. So what I take from this is that, yes, I think we should be adhering to a high ratio transfusion strategy, but that precise makeup, I think we still need more research to figure out what that precise makeup is. But perhaps equally important, or maybe even more important, is how rapidly that product is delivered to the patient. And that's where you get into the communication pieces, find the right patient, and having the sort of operational infrastructure in place to rapidly activate and get product to the patient to begin resuscitation as soon as possible.
Okay. A lot of discussion there. That was awesome. That's a great summary of those articles. I think it's fair to say that the authors of that Dr. Holcomb's group probably were hoping for a little bit more of a clear-cut benefit in terms of long-term survival. But I think that what you said is important, that survival bias in microcosm. But I think it's important to emphasize that in both of those studies, and in fact in the Stanford study as well, the key that came through was getting product to the patient rapidly is, and I know I'm summarizing what you just said, but getting product to the patient rapidly in whatever exact proportion is really what we're looking at. And that's been, for me, the biggest benefit of this entire process. Is that, again, fair to say?
Yeah. The key thing about the PROMPT study is those patients who sort of more rapidly achieve those high ratios in the first 6 hours, that's where that high ratio transfusion benefit came in. So I think there's definitely, some science out there to support this trauma-induced coagulopathy premise, and perhaps achieving these high ratios has that sort of physiologic benefit of restoring coagulation factors, and also other factors that may be important in aiding in survival.
Well, so let me throw a curveball at you, though, Min. So we talk about, and you mentioned this phrase at the beginning, kind of recapitulating whole blood, and I threw out a word or a blood product that makes blood bankers cringe everywhere. But again, just to let people that are kind of just beginning in this understand this. Well, why the heck don't we just use fresh whole blood, for goodness sake? I mean, what stops us from just transfusing fresh whole blood to all these patients and not worrying about, kind of artificially creating whole blood?
I think the premise of component therapy began with the idea that the different components of blood have they each have their own ideal storage characteristics, and fresh whole blood, in the military setting may be okay, I guess, because you have your walking blood banks running around with uniforms on, but operationally, to sort of have blood for a large population, it becomes very difficult to maintain fresh whole blood, which probably I would imagine has a very short shelf life, and and so storage of blood at temperatures that might facilitate survival and functionality of platelets may not be very great for red cells,
right,
or the clotting factors, some of which are thermolabile and may deteriorate at room temperature storage. And probably you also get a lot of breakdown in cytokine release from leukocytes and things at room temperature that
sure,
you might not get at refrigerated temperatures. And, there's the issue of, growth of, potentially contaminating organisms that, may not occur at refrigerated temperatures, but do at room temperature or do at a greater rate at room temperature.
Yep.
So I think the component therapy just allows us to have a very robust inventory for the population, and you're storing these components at their ideal storage temperatures and under the ideal storage conditions for each individual product.
Gotcha.
So that's probably why I think there was that move to component therapy. But please correct me if I'm wrong.
No. I wasn't trying to trick you. You're right. You're absolutely right. It's practically speaking a very challenging thing outside of the military setting to do a fresh whole blood process. In fact, I often joke that one great way to make a blood banker sweat is to bring up fresh whole blood, and you'll see the immediate reaction. No, not that.
Right.
So we've taken some time to go through the who, where, what, why, and when. But right here, as we finish this out, let's talk a little bit about some of the practical mechanics. And we've mentioned some of that already in terms of the physical packing of units in a pack, et cetera. I wanted to just touch on one thing real quick in terms of blood product choices for ABO, and we don't have to go into this to an enormous extent. I did a long blog post on this not long ago, the use of different plasma choices. But can you talk to us just a little bit about what the current state of research is on options instead of using AB plasma in all these cases when we don't have the patient's blood type? Are there other options, or are there other things that we can do?
Yeah, so it looks like the industry is moving towards the use of Group A plasma as sort of the quote-unquote universal donor plasma for emergent resuscitation in the setting where a patient's ABO is not available. So this sometimes happens when patients have had severe trauma and perhaps they show up in a very sort of exsanguinated state, and you try to put needles in and nothing really comes out. This patient is just, or maybe there's some issue of getting a specimen to the blood bank or what have you, and you don't immediately have the ABO type. So historically, AB plasma was used, but potentially at the risk of higher rates of TRALI. It's a rare blood type. It's harder to keep on the shelf. Sometimes the TRALI deferral criteria may be relaxed in order to boost AB inventory. So there's been some movement towards use of Group A plasma. There was a small study from Zielinski et al. That was published, and it did not show statistically significantly greater rates of mortality or other adverse outcomes in the small number of patients who received incompatible A plasma. And more recently, there was a study published by the Biomedical Excellence for Safer Transfusion Group, or BEST collaborative, and they did a survey of level 1 trauma centers around the country with a very good response rate. It's actually a 50% response rate, 60 of 121 centers. And it turns out that 63% of respondents reported use of Group A emergency release plasma in the setting of unknown ABO type, and 62% reported no limit on the continuing use of Group A plasma in this group.
Wow.
And 79% reported no effort to assess the anti-B titer of these Group A units that they had on hand in the event that this situation would arise. So I guess that's one of the newer things that's emerging right now for resuscitation in these patients.
It's fascinating, especially the 62% that have no limit on continuing use of Group A plasma. From my perspective, that's the only part that would worry me. I think we have good enough data to know that in urgent situations, if you give a Group A plasma to someone who turns out to be either Group B or Group AB, obviously that's an incompatibility. But if they're not using any limit on continuing to pump that plasma in, I guess, would you? I don't know the answer to this. Would you assume that that's just due to the fact that the patient is continuing to exsanguinate, and you're pumping in Group O red cells, and the A plasma doesn't matter as much?
Yeah, I think so. You're sort of temporarily converting the patient to a group O patient. Yeah.
Yeah. It's kind of an immediate, urgent exchange transfusion in a way, I guess.
Yeah,
that's really interesting. And as I said, I have a more information on the Blood Bank Guy website about this, so we won't take any more time to go into it. So Min, we've hit a lot of stuff. We've done the who, the where, the what, the why, the when, and the how of massive transfusion. I know that there's a whole lot more that we could talk about, but we're getting a little short on time. So I wonder if you wouldn't mind just kind of summarizing for us your kind of take home points for people that are getting ready to have discussions at their local blood bank, or people that are trying to learn about this. What are the key points that people need to remember about massive transfusion?
Sure. Patients who meet massive transfusion criteria, these criteria have been variously defined, but a common definition out there is 10 units of red cells in 24 hours. Massive transfusion is not just for trauma patients anymore. As we discussed, it's now commonly being applied to OB patients, and other patients around the hospital with exsanguinating bleeds may benefit from this as well. A recent randomized controlled trial of 1:1:1 versus 2:1:1 found no difference in 24-hour or 30-day mortality between these two different ratios. Timing and communication are critical during massive transfusion. Tell us where the patient is and where you need the blood, and if you need another round of massive transfusion product. And one of the emerging things is that group A plasma appears to be supplanting AB as universal donor plasma, as demonstrated in the BEST collaborative report. But further research obviously is needed regarding the overall safety and efficacy of that approach.
Awesome. Well, Min, I can't tell you how much I appreciate you being my guest today. That this has been really interesting, and I think you've brought up a lot of really good points for us to think about and to understand as we go through this. Is there anything else you'd like to leave us with as we close?
Congratulations on the Ledeen Award that you got at the CBBS meeting this year. You're very deserving.
That is very nice of you. I appreciate that, my friend. All right, everyone. That will conclude this podcast. Min, thank you so much for being here.
Thank you very much.
Hi, it's Joe with some closing thoughts. Boy, we covered a lot of info today, and I want to make sure that you get the best bang for your buck out of this. So let me just break this down a little bit into summaries for different people that might be listening to us. First, if you're a blood bank worker or a pathologist, boy, I hope that you get out of this that the communication is really key to all of this. It's so important to know who wants what and where and why and all of those things. It's essential that you set up the plan early. You cannot figure out massive transfusion on the fly. You cannot figure it out in the heat of the battle. You have to do the work beforehand, and you have to be ready for when these things happen. For clinicians and nurses that might be listening to this, speaking as a blood banker, it is so important that you just make really sure that the blood bank knows what you want and where we're supposed to send it, etc. Activate that massive transfusion plan when it's needed, and when it is, follow it. And that kind of goes to my second point. Make sure that you know what you want. Make sure that you're in a situation where you have ordered exactly what you're looking for, so that, again, everybody can get exactly what they need to take care of the patients. And finally, for students, a lot of useful information for you on this one. It's really important that you understand the definition of massive transfusion. Most common definition, as Dr. Tran mentioned, is to give 10 units of red cells in 24 hours, but there are a lot of different definitions of that as well. You should understand high ratio transfusion and what that means. And that terminology gets confusing sometimes. You hear people throw around the 1:1:1 thing. So let me just make it simple for you. Red cells to plasma to platelet ratio. That's what 1:1:1 means. And functionally in the United States, for the most part, that really means for every 6 units of red cells and 6 units of plasma, you give 1 unit of apheresis-derived platelets. And that'll vary from place to place, but that's typically what we mean. When we say 1:1:1, we're typically meaning 6 to 6 to 1 red cells, plasma to platelets. There's a lot of debate about whether or not that is truly proven in the literature, and the current studies have not proven it, the benefits to the extent that I think the authors wanted to, but there are still benefits to doing high ratio transfusion and getting the patient the right amount of product as rapidly as possible. Anyway, so I've talked for too long once again. I just wanted to let you know that I appreciate all the great ratings that you've given on iTunes. Thank you so very much. If you have a chance, if you haven't already, please go to iTunes and give us a rating, a star review, and subscribe to the podcast to help us get this in front of more people. And the last thing I want to leave you with is the thing that I always leave you with, and that's as you go through your day, I hope that you smile. I hope that you have fun, and above all, never, ever stop learning. Thanks a lot. See you next time on the podcast.